Hello and welcome to the Neuroblastoma Parent Global Symposium 2021. My name is Donna Ledwinski from Solving Kids Cancer, and it's my great pleasure to introduce our esteemed speakers for this first session, which is about the whole intro to neuroblastoma, coping with diagnosis. So first will be Dr. Ramya Ramanujachar, who is a consultant pediatric oncologist at Southampton University Hospital. And then we have Dr. Daniel Morgenstern, who's the Director of New Agents and Innovative Therapy and Therapeutic MIBG programs at Hospital for Sick Children in Toronto. And then we'll have Dr. Julie Park, who is the Scientific Chair of NANT and is a Professor of Pediatrics and Associate Clinical Researcher at Fred Hutchinson Cancer Center in Seattle. And then we have Jennifer Saggio, who's a neuroblastoma nurse practitioner at Children's Hospital of Philadelphia. As a reminder, I'd like to call your attention to the chat where you can ask questions, and we'll deal with the questions at the end of the presentations. So I'd like to first hand it over to our first speaker, Dr. Ramya, who will be presenting on neuroblastoma basics and terminology.
Good afternoon, and this is from the UK. And it's a real pleasure to be a part of this passionate community that has so much vested interest in neuroblastoma that is so close to my heart. I would like to thank the Solving Kids Cancer also for inviting me to be a part of this organization that is moving from strength to strength. I always think the journey for a child with neuroblastoma is a lifetime, but actually it is a lifetime journey for you as well as a family. And perhaps one of the important things that we often forget is how we can have and hold on to that strength and support in that entire process. And what I hope from this organizational meeting, you will gain some of that in terms of knowledge, as well as how to keep yourselves in terms of strength and passion. Today, I'm going to be doing very basics, just the nuts and bolts of neuroblastoma. So I really apologize to some of the experts in this particular audience if it is very basic, so it might be just a refresher, but I'm very happy to take questions on some of the other aspects that I haven't covered later on. I'm going to look at today very briefly the common and uncommon presentations, mainly look at the current staging and risk stratification, but deconstruct it just to identify and understand some of those terminologies, but also leave you with some resources that you can then refer to later on. As we already know, this is the most common solid tumor we see outside of the central nervous system. In fact, the commonest malignancy we see in infants that is less than a year of age. Although this is a childhood tumor, rarely we do see it in the teenage and young adults and also the adults. And roughly we see about 100 new patients a year in the UK and about 800 new patients in North America. So what is and where does actually this come from? So this is an embryonal tumor, and this arises from what is called the neural crest cells, which are the primitive cells that come from the yolk sac and then travel up to go into the adrenal medulla and subsequently land up in the sympathetic chain that could extend anywhere from the neck, going all the way through the thorax, abdomen, and into the pelvis. Which is why when you look at where the primary site of neuroblastoma is, although predominantly it occupies the adrenal gland, it can also be present retroperitoneally in the abdomen. So abdominal tumors constitutes nearly 2/3 of the primary tumor presentations. But also they can come in the thorax, that is at the back, the posteriorly. They can also manifest occasionally in the neck or in the pelvis, but lesser extent. Metastatic disease can go anywhere, for example, bone marrow, lymph nodes, and occasionally even into the central nervous system. So if we look at the common presentations, it depends on where the tumor has risen. For example, in the abdomen, it could be a palpable mass, which in turn can cause many problems, including weight loss. If it was in the pelvis, it can cause problems with the bowel and bladder. In the chest, problems with breathing, sometimes swallowing. And there is a specific syndrome called the Horner syndrome, where the child can manifest, especially in the thoracic tumors or lower neck tumors, with drooping of the eyelids and changes in the pupil size. But really, one of the emergency presentations is when it is present along the spine or beside the spine, they can actually enter into the spinal canal and spinal cord, causing compression and hence neurology such as paralysis with blood and bladder dysfunction, which can happen at least in about 5 or 10% of the children, or 5 to 15% of those children, which is classed as an acute emergency. If it is a metastatic disease in the infants, they could present with a very large liver that can cause compromise to the breathing. Sometimes these subcutaneous nodules, which are really metastatic deposits in the skin, can also be seen. If the bone marrow is infiltrated, they present with some of the features that children present similar to leukemia, such as prolonged fever, weight loss, anemia, and in and around the eyes, we call this specific feature of bruising called ecchymosis. And not to forget, there is the chemicals, the catecholamines that are released by these tumors that can cause some of the manifestations like excessive sweating, hypertension, and watery diarrhea. Very rarely, neuroblastoma primarily presents in the lungs and CNS, although relapse can go to the CNS. But also there is a very peculiar autoimmune phenomenon, which we refer to as paraneoplastic syndrome, where the child has got features of what we call opsomyoclonus, where they can have these dancing ocular movements, which could be horizontal, vertical, rotatory, associated with also features of myoclonus, that is jerking. And this is often seen in thoracic, but has a better prognosis, but neurologically, they could have long-term issues. So following presentation, now let's move on to how do we diagnose neuroblastoma. Obviously, I can't go through all of these, but just to understand, the gold standard is to get your tissue. And as we know, the tissue can be obtained from the primary tumor, sometimes from the skin nodules, but also we do what is called bilateral, both sides, bone marrow aspirate centrifines. Then there are a number of standard blood tests that we do, in particularly looking for some of these markers, but also measure sometimes a very quick test, that is the urine for catecholamines, HMMA, HVA. But these do not have, that is the tumor markers in this context do not have any prognostic significance. And ultimately, it's putting together all of these imaging and the biopsy that we finally make the conclusions of how to manage. And the various imaging modalities that are being used will be, for example, the MRI scan, MIBG, which is meta-iodobenzylquinidine, which is a specific marker that is taken up by the neuroblastoma cells. And almost 90% of the tumors are avid. In rare instances where they are not, we would be requesting a PET CT scan. So this is just an example to show you how the CT is helpful in the context of a bone involvement and helps to differentiate between the bone involvement on the skull and separate it out from the brain parenchyma, because this would be a slightly different management. And the MRI scan also helps us in characterizing the tumor. So it is not just at the time of diagnosis, but it's important to characterize what is the volume of the tumor, where is the extent of the tumor, because as treatment moves on, at certain time points, we are going to be looking at response. And we substratify this into a partial response, a very good response, stable disease, details of which I can discuss later, but these are important things that we need to mark right at the beginning and follow it through. This is an example of an MIBG scan, and as you can see, there are many dark areas here that we refer to as avid disease. And now we have a scoring system that has been developed by both the SIOPEN and the North American, although slightly different, is being used at the time of diagnosis and response assessment to see the response and substratify how to manage it subsequently. So it is all getting very sophisticated. So the histopathology is what we get from the biopsy sample. And typically, there are 3 types of neuroblastic tumors. They start from what is called the immature tumor, which is called the neuroblastoma, that is undifferentiated, meaning it's got all these small round blue cells on a background of pale pink, which is not really much. Then you can see these rosette formation, which is in the poorly differentiated, and gradually they start getting a little bit more differentiated or mature. In other words, these small round blue cells become the next step, which is called ganglion cells. So depending on the proportion of these ganglion cells, if they are less than 50%, then the next stage in the maturation is called the ganglion neuroblastoma. We again subdivide this into mixed nodular. And finally, when all of these mature, then that is called the ganglioneuroma, which has got predominantly ganglion cells. So why is all this important? Except for the mature and the intermixed ganglioneuroblastoma, they have a favorable histology. The others have got an unfavorable histology, particularly the undifferentiated, poorly differentiated neuroblastoma, which is really becoming important in the context of risk stratification. And secondly, following surgery, we want to see what the response is, because we expect that these tumors become more mature with time and with a good response to treatment. But really, the crux of how research has moved forward in the last decade is the change in molecular pathology and the various diagnostics that are now available. Fluorescent in situ hybridization is a standard technique that has been used for many decades now to detect what is called the MIBG amplification. And as you can see here, there are only a few of these red dots or pink dots, but here you can see how multiple pink dots are here, and that is what we refer to as MIBG amplification. And this we know is associated with very poor risk, and roughly we see that in about 20%, 25% of our tumors. We also look to see what has happened to the chromosomes. For example, we can have loss of some part of the chromosome, gain of some part of the chromosome, and these again have a prognostic significance. For example, loss of 1p11q is poorer prognosis. Lots of analysis and looking at polymorphisms is being done by breaking down the cells and looking at the analysis of the DNA. And genetic mutations, like for example, we know now the current European study is looking at abnormalities in the ALK gene, and this is roughly about 10% of the tumors. And similarly, few other gene mutations, very few of which I've named here, is being looked at. But obviously, all of this is dependent on having your tumor sample and having a bulk of that tumor sample. But there is ongoing research in the context of when your child has finished treatment, how do we know, and how do we know quickly that this is not coming back? Can we have any blood markers? So for that, there is ongoing research now looking at what is called the circulating DNA or the ctDNA to see can we actually detect minimal residual disease before it has actually manifested in the form of looking at it in the scan. So all of this is now being used in the stratification, and also some of these DNA markers, biomarkers is being used in the context of treatment and treatment direction, which is all very exciting. So I'm now going to move on to the last part, which is the risk stratification. So as you can see, we have the SIOPEN, the European, and the Children's Oncology Group, or the COG. And they use different criteria. Many are similar, but some are slightly different, such as age being similar, the MICN status being similar, the staging, the histology. But in addition, the Children's Oncology Group also use what is called the International Neuroblastoma staging stratification that I'm just going to very briefly mention. So as you will be familiar, this was a staging system that was developed way back in 1986. And if we follow this, the column on the left-hand side, it goes from stage 1 to stage 4, and there is a 4S. Stage 1, again, based on the characteristics of the primary, characteristics of the spread, will be a localized disease or a localized disease with lymph nodes negative or lymph nodes positive, or it might be an unresectable disease. So I'm not going to go into all these details, but you can see what was obvious from this is it's all dependent on what the surgeon sees when they go in and what the pathologist comes back with. In other words, it's only a post-treatment assessment and doesn't tell you how to start treatment. And that is where a whole initiative by the International Neuroblastoma Risk Group stratification came up. And we now stratify tumors based on what is called the L1, L2, M, and MS, based on not just where the tumor is, but also a list of what we define as image-defined risk factors, meaning we look at the scans, there is a discussion with the surgeons, how easy, how difficult is it to completely resect it out? Is the tumor having problems with, or rather, is the tumor wrapping around blood vessels, wrapping around vital organs? So all of those decisions are made by looking at those images. So based on that, we've got image-defined risk factors, which then stratifies your tumors. Stage M will be the metastatic disease, and MS is a special type where we see it in infants with involvement of the skin or liver or a bone marrow less than 10% and lymph nodes, but not in the lung, the pleura, the bone, and the CNS. So out of this, the European way of looking at low and intermediate risk, I'm not going to go through this, but you can see there are areas that are in yellow, which is the low risk, and the intermediate risk, and they are stratified based on L2, age, MECAN amplification, and we divide them into 10 groups. And based on that, we decide whether we just observe, for example, in the lowest group, or we have to treat them with chemotherapy plus or minus radiotherapy. So what is a low risk? So the low risk are those who have a very good outcome, as we know, and these are essentially the L2 who are less than 18 months stratified by biology or presence of symptoms, or the special group of MS who are less than 12 months stratified the same way. The intermediate risk groups are those children who have the L2 disease over 18 months, once again stratified by pathology, or the L1 MECAN amplified tumors, or now we also have the metastatic disease less than 12 months with bone and bone marrow, or CNS. The high-risk groups are all of the patients who have metastatic disease with or without MECAN amplification, and L2 MS with MECAN amplification. But obviously the L1 with MECAN amplification and stage M less than 12 months were previously high risk, but they are now moving to the intermediate risk. Obviously, we have also recognized that not all children need the same amount of treatment by identifying the very low risk groups, which are the L1 with no MECAN amplification or segmental chromosomal abnormalities, meaning the loss or the gain of the chromosomes. And similarly, the MS group, less than 18 months with no abnormalities in the genetics. Then there is a very special group where on evaluation, for example, they've had a scan at the time of birth, they were detected or antenatally neonatal adrenal masses less than 3 months of age, and we might just observe them. And then the ultra high risk is another group that is beginning to be defined, which I'm sure Dr. Daniel Morgenstern will be going into detail later. So with that, I'm sorry, it's been a very quick tour, but important thing is at the time of diagnosis, do sit down with your oncologist, your nurse specialist, try to understand some of these jargon that we are letting you know. And obviously there are different time points during treatment. It could be at the time of diagnosis, it could be time of relapse. Do check to see what are clinical trials available. Where do I get my second opinions? What is the latest research? Yes, that's all fine with information, but what's most important is how do you get your support? How do we cope? So be aware about the emotional, the practical aspects in the organization and the organizational aspects. And lastly, there are a lot of resources, so please access them. For example, now the Solving Kids Cancer is doing this fantastic job of bringing you all together. So in summary, I would like to say there are a number of exciting advances in the biological characterization, which is now driving therapy. But ultimately, it's understanding the age, the stage, the histology, and the biology that is what's going to determine the treatment and the prognosis. There is a large international collaborative effort for improving outcome, particularly in the context of high-risk neuroblastoma. And the INRG, that is the International Neuroblastoma Risk Group Stratification team, or you can say the committee, is trying to harmonize this risk stratification across the world so that we can have comparisons and move forward. So with that, I'm going to leave you with a number of these resources. You have my slides, which I must say have been helpful even for us, which I keep looking quite a lot. And I wish to say thank you to the Solving Kids Cancer, all of my colleagues who are working so hard. And of course, nothing can happen without you, parents and families, to support these children through this difficult journey. And our Children's Cancer and Leukemia group in the UK has also got a lot of resources that you can look into. Thank you.
Dr. Ramia, thank you so much for that excellent presentation. Now over to Dr. Daniel Morgenstern to talk about the treatment for high-risk neuroblastoma. Thank you, Daniel.
Thanks so much, Donna. So Ramia has given a overview of the entirety of neuroblastoma. Now I want to focus specifically on how we treat high-risk neuroblastoma, which makes up about 50%, half of patients with neuroblastoma. Very briefly, these are my disclosures. So one of the questions is obviously, what is neuroblastoma? What is high-risk neuroblastoma in particular? And we've already heard about this. The edges of this are actually very complicated, but as we've heard, there are two groups that are always considered to have high-risk disease. Those patients with metastatic disease who are not babies, and pretty much every patient whose tumor has MYC amplification, this particular gene that seems to drive neuroblastoma. There are some subtleties to this because we're still working out how best to manage infants with metastatic disease and to work out exactly where that threshold is between being an infant and not being an infant. And it's important to recognize that there's this other group of patients who have localized but unresectable tumors without MYC amplification, but with unfavorable biology. And the importance of this group is that they're just treated slightly differently on the two sides of the Atlantic. That in North America, they've been considered high risk, and in Europe, traditionally, they've been considered for non-high risk therapy, although actually that's beginning to change. But by and large, the stratification, the way we treat these patients is similar wherever you are across these collaborative groups. So this is just to give a kind of bird's eye view of high-risk therapy in Europe in the SciPen-2 study, and in North America with the current ongoing Children's Oncology Group ANBL 1531 study. And this slide is sort of deliberately complicated because I just want to put it all in one place. And then I want to use the rest of this time to really take us through this and to highlight why we've ended up where we are now. This, as you can tell from the slide, is very complicated. And I think treatment for high-risk neuroblastoma is probably among the, if not the most complicated and intensive therapy for cancer anywhere. And we've not made this up. This treatment has come about because of multiple clinical trials that have happened in the past, with us learning from the results of those trials to work out where to go next, how to improve outcomes for these patients. So let's just begin to break this down and talk about the different elements that go into making up this overall treatment strategy. So this slide kind of simplifies things, and there are two ways of dividing it up. Either you can divide the treatment for high-risk neuroblastoma up into 3 phases of induction, then consolidation, and then maintenance, or to put a little bit more detail on it, induction chemotherapy, followed by surgical resection, and then high-dose chemotherapy and radiotherapy for consolidation, and then immunotherapy maintenance. And it doesn't really matter how you divide it up, but this overall strategy for treating high-risk neuroblastoma is pretty much the routine, at least across Europe, North America, Australia. So what is induction chemotherapy? So chemotherapy given in multiple combinations using multiple different chemotherapy drugs with the idea that we can shrink down the bulk of the primary tumor and get control over the metastatic disease. And we use multiple different chemotherapy drugs so that we can target the tumor from sort of multiple directions at the same time to try and overcome resistance. And the details of this are actually very complicated, but the principle is the same, that we're really using chemotherapy to try and get initial control of the disease. So what do we already know about this? So work that's been done in the past compared this combination of drugs called Kojek, and each of those letters just stands for an individual chemo drug, and compared standard Kojek, which was giving chemo, waiting for the count to recover after 3 weeks, and then giving it again, with rapid Kojek, which is where the chemotherapy is given in a very clever schedule, but it allows the chemo to be given every 10 days, regardless of the counts. And so a study that was done quite a long while ago showed that the rapid version was better than the standard version. And that's why Europe then adopted rapid Kojek as the standard induction chemotherapy. Most recently, the SciPen group did a randomized study comparing this thing called modified N7 chemotherapy, which is just another combination of drugs, against this standard of rapid Kojec, and showed that the outcomes appeared to be no better for the modified N7, but it appeared more toxic. And so that's why at the moment, at least in Saipan, rapid Kojec is being taken forward still as the standard. Meanwhile, in North America, we were using a slightly different combination of chemotherapy medicines, and a pilot study was done which showed that the response after 5 cycles of chemotherapy appeared to be as good as after 6 cycles. And so in the children's oncology group, we now routinely give 5 cycles of chemotherapy. So that's what we knew. And what are we doing now? So in the current high-risk study in Europe, as I mentioned at the beginning, the German group called GPOH has recently joined the collaboration with Saipan. And so the German group had actually had a rather different induction regimen from the rest of Europe, using a different combination of drugs. And so in the current high-risk study in Saipan, we're putting head-to-head that standard in Europe, the rapid Kojec, against the German standard, again to see, is there a difference between these in terms of response rate, in terms of how it affects the disease, and is there a difference in terms of toxicity? And so this is the study that's going on at the moment. In North America, we have the COG ANBL 1531 study, and this is asking a different question, which is, there is this type of treatment called MIBG therapy, which is a type of molecular radiation, essentially radiotherapy given as a medicine, which for many years has been used to treat neuroblastoma that has not responded to initial treatment or has come back in the relapse setting. And it works quite well in that setting. And so this study is asking the question, well, what happens if we added this treatment into the induction? Could we get better control of the disease, and could we improve outcomes for these patients first time round? And so in this study, we're randomizing patients between either our standard induction, which is 5 cycles of chemotherapy, or the standard induction plus the MIBG therapy. And as I show here, it's given after cycle 3. And this study is ongoing, and we don't know the answer to this question at the moment. Surgery is clearly very important in neuroblastoma. I'm not a surgeon, so I'm not going to talk in detail about this. Suffice it to say that despite neuroblastoma often being a metastatic disease, which means it's spread around the body, there is evidence that getting a good resection, a good removal of the primary tumor does correlate with improved outcomes. So surgery is still an important component of the treatment. Then comes this thing called high-dose chemotherapy, and we're going to talk in more detail about high-dose chemotherapy in a later session that I'm leading. But just to highlight at this point, this question, what is high-dose chemotherapy? So really it's in the name, which is that we are giving higher doses of chemotherapy. The implication of this is shown in the graph here. So normally after we give chemotherapy, the blood counts drop down. We give G-CSF and we wait for them to recover, and it takes 2 to 3 weeks. And when the counts have recovered again, we give another round of chemotherapy. The blood counts drop down, we wait for them to recover, and we give another round of chemotherapy. In high-dose chemotherapy, the same thing happens, which is that the chemotherapy affects the blood counts and suppresses the bone marrow, but actually in a very, very profound way, such that if we didn't do anything, the bone marrow might not recover on its own. Clearly, we can't leave the patient without a functioning bone marrow. And so in order to allow the bone marrow to recover, we give back the patient's own stem cells. And giving back those stem cells then allows the bone marrow to recover. So ultimately, what the high-dose chemotherapy is a way of giving more intensive chemotherapy to try and kill any remaining neuroblastoma cells that are there. But in order to safely give that chemotherapy, we have to give stem cells back. What do we already know? So the Saipan group quite recently published the comparison between Bumel, which is the name of 2 chemotherapy medicines, which have been the European standard, comparing that against SEM, a combination of different chemotherapy medicines, and showed that at least after the rapid Kojec induction, and I think that's very important, after the European induction, Bumel was better than SEM. Meanwhile, in North America and the Children's Oncology Group, in a study led by Dr. Park, who you're shortly going to hear from, we compared patients receiving 1 high-dose chemotherapy episode compared to a tandem high-dose chemotherapy, which meant you give high-dose chemotherapy, you give the stem cells, you wait for their counts to recover, and then you do it again, actually with a slightly different combination of drugs. But the idea of giving more high-dose chemotherapy. And importantly, that study showed that the tandem high-dose chemotherapy had a better outcome than single. So what are we doing at the moment? In the SciPen group, in the current high-risk study, in addition to this randomization of induction chemotherapy that I mentioned already, there's a further randomization, which is to compare the standard in Europe, which is busulfan and melphalan, against a tandem high-dose chemotherapy with thiatipa and then busulfan melphalan, to see whether an extra high-dose chemotherapy regime is able to improve outcome for these patients. In the children's oncology group, we are moving forward with the tandem, and I've just put here the names of those drugs, which are cyclophosphamide thiatipa, followed by SEM. And in the current study, ANBL 1531, there was a randomization against Bumel, but actually at the moment that arm has been closed, and we're moving forward only with the tandem. Radiotherapy is the next treatment component after high-dose chemotherapy. And again, there's quite a lot that could be said about radiotherapy, but I'm not going to go into it in detail. Suffice it to say that the purpose of the radiotherapy really is to further achieve local control and try and prevent any of the tumor that's at the primary site that maybe not been resected by the surgery, try and prevent that from regrowing. And there's lots of detail to go into about exactly what dose to give, and the discussion to be had about, do we give radiotherapy to metastatic spots that are left? But to conclude, radiotherapy is an important part of the treatment after the high-dose chemotherapy to try and prevent the neuroblastoma from regrowing at the original site where it grew. And then the final component of treatment is immunotherapy. And what do we already know about immunotherapy? So the Children's Oncology Group study led by Alice Ewan, published several years ago now, showed that giving this immunotherapy, actually a combination of anti-GD2 antibody together with GM-CSF and IL-2, which are drugs that help to boost the immune system, that the outcome of patients who had the immunotherapy compared to those who did not have immunotherapy was better. And so that's why both collaborative groups have now adopted immunotherapy as a routine part of our treatment for high-risk neuroblastoma. And in Europe, in the SciPen group, they asked a slightly different question, which was to say, does giving the IL-2 help to enhance the effectiveness of the antibody? And the answer seemed to be, well, no, not really. It doesn't seem to improve outcomes, but it certainly makes the side effects worse. And so Europe in their study, and actually now the Children's Oncology Group as well, has dropped IL-2 from the immunotherapy treatment. So what are we doing at the moment with immunotherapy? And the answer is something that's very similar, but subtly different between the two collaborative groups. So in SciPen, we're using an antibody called dinutuximab beta, which is an antibody against this molecule called GD2. And it's given without any cytokines, without any of these medicines to boost the immune system, in combination with this drug called retinoic acid, also called Accutane, which is designed to push any remaining neuroblastoma cells to kind of grow up, to differentiate, to turn into benign tumor cells. In the Children's Oncology Group, we're using a very similar but slightly different antibody called dinutuximab, and we're giving that in combination with GM-CSF, no longer giving it in combination with IL-2, and we're also giving that with cis-retinoic acid or Accutane. And then finally, as I briefly mentioned, we are now also moving towards the area of molecular selection, so trying to target specific gene changes in a subpopulation of patients with high-risk neuroblastoma. And so for these relatively rare patients who have abnormalities in this gene called ALK, in the current study in North America, we're giving them a drug called crizotinib. And very soon, that study and the European study, we hope, are going to be amended to include a slightly newer drug called lorlatinib, which inhibits ALK, so that these patients who have these ALK aberrations are going to receive a targeted drug in addition to all of that treatment that I've spoken about. So in terms of take-home messages, I think the key take-home message is that the two main collaborative groups for neuroblastoma research, COG and SciPen, have broadly similar treatment strategies for high-risk neuroblastoma. That increased treatment intensity does appear to improve outcomes. And so each of the studies that have been done recently, the addition of immunotherapy, tandem versus single high-dose chemotherapy, are adding things to the treatment. And each time we've managed to improve the outcomes. And on the one hand, I think we recognize that that's really important to improve outcomes, but it does raise an important challenge of late effects and of the toxicity and of the burden of treatment and how far we can continue to increase the intensity of the treatment. And then finally, just to emphasize that the treatment that we recommend now is built on previous research that's happened, and we are trying our best through current studies to continue to refine that treatment to make it as good as possible so that we can continue to learn from what we do and improve outcomes. Thanks very much.
Thank you so much, Dr. Morgenstern, for that excellent and fantastic, clear presentation. Next, we have Dr. Julie Park, who's going to be talking to us about advances in imaging for neuroblastoma. And we're lucky to have her today because she's actually in 2 different meetings at once. Thank you, Dr. Park.
Thank you, Donna. It's really a pleasure to be here, and I'm sorry that I am in 2 different meetings, but it's worked out perfectly. So I was asked to give an overview of imaging for neuroblastoma and our recent advances. And I think this will go nicely with the 2 talks that we've had so far, because there's some overlay, but really with the perspective of how we think about imaging neuroblastoma and what we use it for. So if I can have the next slide, please. So I think of the role of imaging for neuroblastoma really in 3 buckets. One is staging at the time of diagnosis. So what you've already heard earlier today is that we utilize patient's age, disease stage, and then combine that with molecular histologic features to come up with what we assign as a risk category. And you've heard those already mentioned: low risk, intermediate risk, and high risk. And it's important that we assign risk appropriately because our therapy recommendations are completely dependent on the risk categories that we give a patient. So we'll go into how imaging is utilized for staging of neuroblastoma. Then obviously therapy starts, and it's really important that we think about how we evaluate response to therapy. And by and large, it's by imaging. And so we'll go quickly through some of the response criteria and really highlighting that the revised International Neuroblastoma Response Criteria really incorporated nuclear imaging, or what we call functional imaging, to help us evaluate disease response, especially at sites of metastatic disease, to evaluate how therapy is going for a patient. And then finally, I think about imaging and its role for monitoring for disease recurrence after completion of therapy. Next slide, please. So we've already gone through a little bit earlier today, neuroblastoma staging. The current International Neuroblastoma Risk Group staging system utilizes 3 main categories: L1, L2, and metastatic, and then a special metastatic site. And it's important to understand that what we call image-defined risk factors decide whether the tumor is an L1 tumor or an L2 tumor. So what are image-defined risk factors? They are tumor characteristics that are determined by imaging, as the name might suggest, and that these risk factors actually predict for an increased risk of complications associated with surgery and an increased risk for recurrence. So they predict outcome as well. Next slide. So what I depict here is a baby with neuroblastoma. You'll see that where the white arrows are, the mass begins in the baby's chest. It's in the central chest. It's wrapping around the spinal canal, spinal column, so you cannot see the spinal column. It's wrapping around that white linear structure, which is the aorta. And then where the 2 stars are lower, it's expanding and extending down into the abdomen. So these are all what we call image-defined risk factors. So extension across compartments in the body. So it's starting in the chest and going down into the abdomen. It's encasing blood vessels by more than 50%. It's compressing vital structures. So in this case, the aorta, and what you can't see very well in this because are the airways that are embedded within the mass, and it invades into the spinal canal. Next slide, please. These are schematics to help you understand a little bit better. On the left-hand side, you can imagine a tumor that's more encased in its own packaging, and it abuts against blood vessels, so those red things, but it does not go completely around the blood vessel. It may push into them, but it does not completely eliminate the lumen, the inside of the blood vessel. So on the left-hand side, that would be tumors that do not have image-defined risk factors, whereas on the right-hand side, you can see the blood vessel goes right through the tumor, so the tumor is wrapped completely around it, or it completely ablates the lumen of the blood vessel, and those are image-defined risk factors. Next slide, please. And then in regards to vital structures, this is a kind of cross-section looking in on the body with the spine at the back, the chest at the top of the screen. And you can see that this tumor in vital organs is extending into the spinal canal. On the right-hand side, it's pushing on the bronchus, airways. It's decreasing vessel size. So all of those are image-defined risk factors. So again, on the right-hand side, a tumor that has image-defined risk factors, and on the left-hand side, one that does not have image-defined risk factors. Next slide. And then importantly, at diagnosis, we also use imaging to detect metastatic disease. So we use what we call anatomical imaging, which are CT, MRI scans to look for image-defined risk factors. And we might also be able to tell that there are distant sites of disease using those modalities, especially if there are distant lymph nodes, or if there's soft tissue arising from bone sites that are metastatic sites. But CT and MRI are not traditionally used to look at bone sites because you don't always see when there's abnormalities in the bone. And once a bone does have abnormalities, those changes can persist for a very long time on CT and MRI and not necessarily mean that there's active tumor there. So to really evaluate bone sites, which is one of the most common sites of metastatic disease in neuroblastoma, we rely on nuclear imaging, or what we call functional imaging. These will actually enable us to identify sites of disease at the time of diagnosis, and as we'll talk about, ultimately evaluate response to therapy. Historically, technetium-99 bone scans were used, but these really are no longer commonly used in countries with advanced economies and healthcare systems. And the reason is that, yes, it can pick up abnormalities in the bone at the time of diagnosis, but it is not as sensitive as some of our other modalities. And similar to what I just said about CTs and MRIs, changes in the bone on bone scan can persist well after there is no tumor there, because healing bone will also have increased uptake of technetium-99. So instead, we've really used two different functional imaging assays. The most commonly used is radiolabeled MIBG scintigraphy. And for those children whose primary tumor does not take up MIBG, we use what we call FDG PET. Next slide, please. So a little bit about MIBG. MIBG is a substance that can be used to detect and diagnose neuroendocrine tumors, which include neuroblastoma. 90% of patients with neuroblastoma have uptake of MIBG in their tumor. So to the right is an MIBG, what we call planar imaging, that shows where the arrow is, a large mass in the patient's abdomen. This is a front view, and then to the right of that, a back view, so it's the same mass. And what you'll also see is those little lines that follow the bone, or kind of a little bit darker at the top of the scalp. Those are all areas of bone metastases also in this patient. Traditionally, or when this was first used in the 90s and early 2000s, MIBG was labeled with I-131 for imaging, but really the quality of those images was quite poor. It was a bit of a snowstorm if you were trying to look at them like this. And it was really the use of I-123 that has led to more adaptation of using MIBG scans worldwide. It's much better quality and was approved, at least in North America, in 2008 for a diagnostic tool. And then more recently, sites have more commonly used a combination of MIBG plus CT scan. So we call those MIBG SPECT imaging. And next slide, I'll show that a little bit more. So here, the MIBG SPECT imaging, you can see how it really bridges the gap between our anatomical imaging, our CT imaging, and our nuclear imaging. And what it allows you to do is see where those dark spots are on the MIBG scan, and then overlay that with the CT scan so that you can really identify the discrete areas where the uptake is. This is quite helpful in really following for response. It's very helpful for surgeons to be able to really identify and localize where they want to go for surgical resection. And importantly, very useful for radiation oncology so that they can really hone in on where we might want to deliver radiation therapy. Next slide, please. So FDG PET is also functional imaging. It is a glucose analog that is taken up by metabolically active cells within the body, again, labeled with radioactivity so that we can take pictures of it. We know that it is taken up by neuroblastoma cells. There have been varying reports about its comparison to MIBG, and there are some situations where MIBG is preferred, and there are situations where PET may add additional information. For sure, we recommend it as primary diagnostic imaging for patients, the 10% of patients whose primary tumor does not take up MIBG. So it allows us functional information about the metabolic activity and sometimes can be helpful in response assessment at the end of therapy. If a patient continues to have MIBG uptake, we can do PET as well. And if it's not metabolically active, we then consider at times that MIBG uptake may be really in a ganglioneuroma tumor, not felt to have the same potential for full metastatic recurrence as an active neuroblastoma tumor would be. Next slide. So I put here kind of an algorithm of how we think about imaging for neuroblastoma. At the time of initial diagnosis, it's mandatory to do anatomic imaging with MR and CT scans, and at least a single MIBG scintigraphy to evaluate for metastatic bone disease. Optional or alternative imaging are really as follows. If the primary tumor does not take up MIBG, then we recommend FDG PET to assess for metastatic disease. If the patient has any concern for neurologic symptoms or concern that the tumor may be invading into the spinal canal, then an MRI of the spine is required to better evaluate. And similarly, if the patient has uptake in the skull base or the orbits, then at least at diagnosis an MRI of the brain to really fully evaluate for any extension of the tumor into brain parenchyma should be evaluated. Next slide, please. So now I'll move on to response, and this could be a whole talk in and of itself, but I just want to kind of take the basics of a revised INRC, which is the International Neuroblastoma Response Criteria. And the way we thought about this is that there are really three components that all have to be brought in together to evaluate overall response to therapy. One is what is happening at the site of the primary tumor. And there we just measure along the longest dimension of the tumor and follow that over time. MIBG or PET certainly can be used because sometimes there is residual soft tissue that again could just be scar tissue, and those functional imagings help us to evaluate that. Secondly, we need to look at any metastatic sites, whether it be soft tissue or bone. And there, again, if it's soft tissue, CT and MRI can be evaluated, but MIBG scans or PET scans are needed to really assess those metastatic lesions. And then, not really relevant to this talk, but the whole other site of metastatic disease could be in the bone marrow, and we evaluate the bone marrow. And we look at response across each one of those categories and put that together to give an overall response. Next slide, please. So how do we look at response looking at functional imaging? There's two main criteria that are used worldwide. One is the Curie analysis, which is used more commonly in North America, and the other is the Syopen analysis that is used more commonly in Europe. They're very similar, and the main idea is that the body is divided into various segments. There's an extension score, so meaning how much of that segment takes up the MIBG tracer. And then you have a score that you start with, and you follow that score over time. So what we've really noticed or been able to compare across the two is that really, regardless of how we divide up the body, the better you respond over time, the better you do, which is not really that surprising. And that the two systems end up coming up with very similar output in the end of how quickly a patient's response can predict also how well the patient does. There's no functional scoring system for FDG PET, so the INRC has said we basically count the numbers of sites, we don't use any extension cord, and we compare that over time. So a complete response would be to a point where there's no abnormal uptake in any of these segments. A partial response would be at least a 50% reduction in the baseline score. And progressive disease is any time that we see a new site of uptake or a 20% increase in the score. Next slide. And then a few more slides just on where we're going with imaging modality. We've learned a lot from being able to have better functional imaging with both I-123, MIBG, SPECT, and FDG PET. And so there's a lot of work in trying to understand how we can develop even superior imaging quality so radiologists can more easily evaluate these scans, have imaging techniques that maybe improve the detection of all disease sites, even down to a smaller amount of active disease at those sites, so we can better evaluate patients and really understand which patients at the end of treatment might still have disease there that we can't detect with our current modalities. And so I list here about 4 different active agents that are under investigation. They're all forms of radio-labeling substances that are either produced or taken up by neuroblastoma cells. So carbon-11 hydroxyephedrine, carbon-11 epinephrine, fluoride, fluoro-18 dopa, and then fluoro-18 benzoguanidine. So basically you'll hear people refer to this as a PET MIBG. Next slide, please. And that final imaging modality, the F18 MBG, has potential advantages over traditional MIBG. It was initially investigated at Memorial Sloan Kettering, and there are some early trials of 10 patients with neuroblastoma where they were able to detect more sites of neuroblastoma using this new modality compared to I-123 MIBG. The other advantages is that the imaging itself occurs on the same day as the injection of the substance, as opposed to MIBG, where the patients receive the injection of MIBG and come back the next day for imaging. The duration of the imaging is shorter than what it takes to do a traditional MIBG SPECT. We don't need to block the thyroid blockade because we're not using the thyroid because we're not using radio-labeled iodine. So there's less risk for damage to the thyroid. And potentially we're delivering a lower radiation dose overall. Next slide, please. And as I said, there was a publication by Memorial Sloan Kettering, which has led us to question whether the use of F18 MFBG can really be proposed for use instead of I-123 MIBG. Next slide, please. So within that context, we, through the New Approaches of Neuroblastoma Consortium, in collaboration with Illumina Radiopharmaceutical, are running an open label multi-center study to assess whether this new imaging modality could be evaluated in patients with neuroblastoma, and whether it is more sensitive and specific. So in terms of finding more sites, and in terms of evaluating sites of disease that have truly responded to therapy in patients with neuroblastoma. And the hope is that by conducting this trial, we can gain more information about this imaging modality and go to the FDA and discuss whether this should be considered in lieu of I-123 MIBG. Next slide, please. That is all I have for today. Thank you very much for your attention, and I'm happy to try to answer any questions.
Oh, thank you so much, Dr. Park, for this great presentation on such an important topic. Actually, we're going to do our question and answers at the end, which of the next session, but we sincerely appreciate that presentation. So next up is Jennifer Saggio. She's going to be talking about dealing with acute side effects. Jennifer.
Hi, Donna. Thank you. Hi, everybody. As Donna said, my name is Jennifer Saggio. I'm a nurse practitioner at the Children's Hospital of Philadelphia, and I'm going to talk with you about side effects today of the treatment for neuroblastoma. So first, what I want to say is the side effects can be similar with different types of treatments. So the good thing about that is once you get a handle on how to manage the side effects for your child, then hopefully you can use that information as you move forward with treatment to make things more manageable for them. On the other side, there are therapies that have completely unique side effect profiles. So getting a handle on that can be a little bit more challenging as you go through. Also, each child responds differently to therapies. Some experience every single side effect as they go through treatment. Others experience very little or just some of the side effects. Anticipatory guidance is necessary. Now, that's our job. It's our job to prepare you for what you're about to endure. So the treatments your child is going to get and the side effects that will happen, that may happen, that might happen, and then how are we going to manage them? How are we as a healthcare team going to manage them? How are you going to manage them at home? We need to work as a team to do this. There needs to be open lines of communication. So it's so important to be able to reach out to your team to discuss things that are going on an ongoing basis and be able to talk through those things and find solutions for these issues. You need to know who to call and when, and your healthcare team will give you that information. There's someone you can speak to all the time, whether it's during the day, maybe a nurse in the clinic who is there to answer your questions and who has access to all working in the different clinics, so they're able to help you. No is too little. That's another thing I want to stress. You shouldn't be sitting at home worrying, wondering, what am I going to do? I don't remember how they told me to deal with this. I'm not sure if this medicine is the one to give. You need to reach out and help you with that. The best way to manage the side effects is with advanced preparation. So we need to give you the information you need. We need to give you the tools that you need. So whether they're medications, to have on hand, to have prescriptions for, just to know what to do. So some of the acute side effects from therapy, obviously I'm not going to discuss everything that could potentially happen, but some of the more the ones that are experienced a little more often include the following. So nausea and vomiting. We can give medications to treat that. There are medications that we can give before certain therapies to treat the nausea that we know will come about. Alternative therapies often work really well for nausea and vomiting as well. Things like aromatherapy, acupuncture, acupressure. There's also times when it's not even the treatment that causes the nausea or the emesis. It's anticipating it. And we call this anticipatory nausea and vomiting. And that is something, again, that we can help you manage with. There's certain medications like Ativan that can help with that. And there's also different practices that we can help you with to, things like guided imagery. It will help kids that are a little bit older deal with something like that. Anorexia, so loss of appetite. These therapies can be really hard on your kids and they just don't want to eat. So how do we treat that? We don't want to have severe malnutrition, obviously. So are there things that we can help with? Maybe appetite stimulants. Can we teach you how to boost up the calories in foods? Maybe drinking high calorie drinks, different kinds of supplemental nutrition, maybe as far as feedings, tube feedings of some sort. Fatigue. So this is one that a child may experience throughout their treatment. So learning to help the child deal with the fatigue and, take a break when they need to, naps, earlier bedtimes, and just optimizing periods of time when your child feels better. So when they do feel good, to do those things they like to do the things they need to do, schoolwork, things like that. So that they just don't have that overall feeling of fatigue all the time. Headaches. We can, of course, give pain medicines for that. There's also different types of alternative treatments that are helpful in that realm as well. Constipation. This can alternate with diarrhea, which is the next one I'm going to talk about. So, that fine balance between stool softeners and laxatives for the treatment. Changes in diet. So fiber is a great thing to use either orally, taking pills or some kind of supplemental drink that has fiber in it, or if they're on formula feeds, to add formulas that have fiber. Fiber is one of those great equalizers. So it works if you're constipated and also works if you have diarrhea. So keeping that on board is often really helpful. Sometimes we need to use medicines when kids have diarrhea as well. So things that will stop the diarrhea when it's treatment related. And if we find that it's an actual infection from some type of bacteria, we can give antibiotics to help treat that. You can actually have skin burns as a result of radiation therapy. And it's important to let your team know right away if that's happening. And the radiation team can recommend different treatments for that, different types of creams that they're going to have you use. And it's really important to just use the products that they tell you about. Pain, overall pain. So this pain could be from different treatments, and it can sort of come about in different ways. So there's the pains that you get, say, from medications like growth colony stimulating factors. So maybe some aches and pains, overall bone pain. And then there's the pain that kids experience from treatments like immunotherapies, which really is, it's a neuropathic type of pain, and its onset can be really quick and it can be really severe, and it can require a lot of close monitoring and management with things like narcotics and medications like Neurontin. Fevers. Fever is something that children do experience during treatment. So is it during the medicine, from the medicine? Is it after the medicine when your counts are low? So there's different ways to manage fevers depending on when you do experience them. Most of the time, we will get blood cultures and potentially your child will need antibiotics. But if you're at home, you need to reach out to your healthcare provider and talk to them about the fevers. Or they're going to ask you questions like, are they low-grade fevers? Are they higher fevers? And then they will work with you to make a plan for that management. Allergic reactions. Allergic reactions are things that happen with all sorts of medications, even things that we don't use to treat cancer. So your child may have already experienced allergic reactions in the past. We can treat those with antihistamines, and there are sometimes medications that we will exclude in the future based on allergies. Anaphylaxis is a severe, life-threatening form of allergy, and that's an emergency, and we need to intervene immediately with medicines like epinephrine, steroids, maybe more antihistamines, and maybe some IV hydration. There also are side effects that are often experienced post-chemotherapy. So these might be when you're home, you're not in the clinic anymore, you're not in the hospital anymore, and they're things that you will be managing at home. So your child's blood counts will go down as a result of a lot of different therapies. So anemia, thrombocytopenia, neutropenia. So anemia is a drop in red blood cells. And some of the symptoms that you might see if your child is anemic is a headache, fatigue, dizziness, and we can easily fix it with a red blood cell transfusion. So definitely important to reach out to your team when you have any of these side effects, and they'll work on managing that with you. Thrombocytopenia is a drop in platelets, and oftentimes when your child does have this drop in platelets, you'll know because they might be bruising a little bit more easily. Maybe they have these little purple dots on their skin called petechiae. Maybe when they're brushing their teeth, they have bloody gums, or they have a nosebleed, or a little cut seems to bleed a little bit longer than it should. And again, fixable with a platelet transfusion. Neutropenia is when your white blood cells drop, and this could result in decreased immune function, so immune suppression for your child. So there are treatments that we give to combat this, injections with growth colony stimulating factors. So things like GCSF, which is a daily injection, Neulasta, which is an injection that is given every 14 days. Now, these medicines don't stop your child from having neutropenia at all, but the goal is to make it that period of time isn't for an extended period of time. So counts drop, and then hopefully they start to come right back up. Fevers, we talked about fevers a little bit before. They could be low-grade fevers, they could be high fevers. And it's important to reach out to your team based on the guidelines they have given you. So there are numbers that we look at. So maybe a really high fever, 102 degrees Fahrenheit, we would automatically want you to call in, and we'll talk you through, we'll bring you in for evaluation and go through the different steps. Low-grade fevers are also something that can be concerning over a period of time. So again, it's never wrong to reach out to discuss these things with your team. Mouth sores, mucositis, and these are things that we can treat with medications, medicated mouthwashes. And because your child has these things, so if they have mucositis, they're likely to not want to eat. So giving them things like soft foods, shakes, maybe timing the time that they're going to eat shortly after their medications to help with the pain, so that they then can continue to hydrate themselves, can continue to nourish themselves. Alopecia. Now, this is a thing that can be very distressing to kids, to parents, to everyone. So you want to make sure your child is prepared for this, that they do know this is going to happen, and are there things you can do in advance to prepare them? So do you want to give them a haircut in advance so that they're not having these giant clumps of hair fall out, get in their eyes, get on their pillow, get all over them? Do they want to have some sort of wig or head covering or hat in advance? It can be fun to pick out those different things. There are other kids who, really are very distressed by it, and talking about it is often helpful to get your social worker on board to help you and with some of the resources for this type of side effect. So the main thing I wanted to say about side effects was it's so important to be educated on those, right? So being educated, we have consent forms we give you that list all different information about the different side effects. They're not going to be in your hand every time you want to know about a medication your child's getting. You don't bring them to clinic, you don't have them in the hospital. So reaching out to your team and, with each cycle of chemotherapy, asking again, I forget what the side effects are here. Are there different ones, or are there new ones I should look out for? Are these things more likely? Ask for drug sheets that give you information about each drug your child's going to get. And it's not wrong to ask for them every single time so that you have them in front of you. You can remind yourself. These aren't things that anyone expects you to remember all the time. Be prepared. Are there medicines that your healthcare provider gave you prescriptions for that you should fill in advance of a specific cycle of treatment? Make sure you have those on hand. You want to have them at home to give so that you can make sure that you can keep your child at home and manage these side effects. Be on the lookout for anything that's changed. So, there's those side effects that happen frequently, nausea and vomiting. And then there are things that happen more rarely. So just anything that just doesn't seem right to you, it's out of the ordinary. You want to let your team know. You want to reach out and say, hey, does anybody ever have this problem with this medicine? And maybe the answer is no, we haven't really seen it. And we'd like to see you in clinic so we can talk about this. We could see your child, we can examine them. Or yeah, we do see that sometimes, and it's not a problem. So they're easy things to find out from your healthcare provider. Be willing to reach out for help. So make that phone call. If your email is a contact, if you can contact your team through your chart for electronic messaging, do that. Do whatever you have to stay attached to your team. It's very important. Thank you. That's all I have today.
Thank you so much, Jennifer, for an excellent presentation. I think all of the presentations have covered the complexity of this disease in so many different ways. So now we have time for questions, and we have many good questions that have come in from the audience. And so we'll welcome the panelists to join us for our Q&A time. And please, even if the question is directed to a specific person, please weigh in, just jump in if you have extra thoughts on these questions. So our first one was about the Bumel arm of the COG trial, the 1531. Question was if there's any information on why that arm was closed.
So I can take that. So it's tricky because this is an ongoing clinical trial. And so what happens with these trials, especially randomized trials, is that the people conducting the study and us sort of in the public are not able to see the data as the study is going on, because otherwise that might affect enrollment on the trial. But in order to make sure that there is oversight, there's what's called an independent data safety monitoring committee, which is made up of experts in the field, statisticians and so on, who look at the information as it's coming in. And so what happened is that when that committee reviewed the results of the different arms, they decided that it was not the right thing to do to carry on with that arm. So technically, we don't know the details of the findings, but it looks as though it was likely that the outcome for patients on that arm was not going to be as good as those patients on the tandem arm. And so enrollment to that arm was closed, but we don't actually have those data at the moment. And I think it's important to say this does not mean that Bumel does not work. It just means that in the context of that COG study, that it looks as though Bumel was not as good as tandem high-dose chemotherapy.
And that arm, correct me if I'm wrong, included the MIBG element.
Exactly. It also included MIBG and induction. Yeah.
So not exactly equivalent to what's happening with consolidation in Europe. Oh, thank you for that. So the next question has to do with order of treatment. For example, one parent had a child that was going to have immunotherapy before radiotherapy, and then likewise surgery either before or after Highdose or stem cell transplant. Could you speak to some of those decisions, why sometimes the order is changed around?
Yes, I mean, I think there are parts of the order that really matter, in that it would not make any sense to do high-dose chemotherapy first, because the point of it is to mop up residual disease, and that's why we use induction chemotherapy first to get control of the disease. The surgery and the radiotherapy are probably the two components of the treatment that are most flexible in terms of timing. So actually, there's already a difference in the timing of the surgery between COG and SIAPEN. So in SIAPEN, surgery always occurs at the end of induction, once you've finished all of that induction chemotherapy. Whereas in the COG protocols, we tend to do surgery earlier on, actually even before we've done a metastatic assessment. And that ultimately actually is due to just a difference of opinion about whether the chemotherapy makes surgery easier or harder. And I think we'd have to get a surgeon to weigh in on that. Some surgeons argue that the more chemotherapy leads to more scarring and makes the surgery harder. Some surgeons say the more chemotherapy, the better, because it continues to shrink the tumor and makes the surgery easier. And I think sometimes we would deliberately defer surgery until after high-dose chemotherapy if we knew that that surgery was going to involve needing to remove one of the kidneys because of where the tumor is. And so sometimes we've deliberately deferred surgery to protect that kidney until after the high-dose chemotherapy, and then had to sacrifice it at that point. And the radiotherapy, I don't know the details of this case, but again, sometimes what we've done for younger children, where we want to try and avoid radiotherapy in younger patients, is to give the radiotherapy the end of treatment when they've kind of had an extra 6 months of therapy and are a bit older. I don't know, Rami, if you want to comment.
Yeah, no, I would say the same about the role of surgery and whether we do it before the high dose or after the high dose. I think the most important thing that we look at is that kidney going to be affected and therefore the renal function going to be compromised during the high dose chemotherapy? And if the answer is yes, then the surgeons defer the surgery to after the high dose chemotherapy to make sure that we have given the best chance during the high dose chemotherapy. And again, I would say with regards to the infant, the only reason I can think is the infant being quite young. You want to defer the radiotherapy to a slightly later age by a few months.
Right. Yeah.
Provided there has been a good response locally. So that decision must have been made on that.
Thank you very much. That makes sense. The next question has to do with the lorlatinib in both the SIAPEN and the COG trial. The question is, will the COG trial run both lorlatinib and crizotinib? So there's two arms to compare, or will they just switch to lorlatinib?
Yeah, so the answer in short is that they will switch. So at the time when that study was started, crizotinib was the drug for which there was safety data available, and that's why it was chosen. And I think over time we feel as though lorlatinib is probably a more effective drug than crizotinib, at least for some of the mutations. And so patients who are on the study already will have the opportunity to swap over to lorlatinib unless they're very close to the end of the study, in which case they'll finish with crizotinib. But it is going to make the analysis somewhat complicated because we're planning on changing drug partway through.
Right, I'm sure. Yeah, that's a very good point. The next question is, and this is probably good for you, Daniel, talk more about the emerging ultra-high risk group. What information is there on that?
So there's a lot of work going on. I mean, this topic really is about saying, at the moment when we risk stratify neuroblastoma, we have this big group of patients with high-risk neuroblastoma. But actually, although we call high-risk neuroblastoma one thing, it's clearly not. And there's a lot of factors that we already know are very important in determining the outcome for those patients. The patients with localized high-risk disease have a better outcome than patients with metastatic high-risk disease. The patients who are older have unfortunately a worse outcome than patients who are younger, all within that group who are high risk. So there's a lot of work going on to try and work out what are the factors either at diagnosis or in response to treatment that we could use to risk stratify patients within that high risk group. The real challenge of this is what's still unclear is what we will do with that information and how we will actually implement it in practice. I think, probably the first thing that we will do actually is what we're beginning to do now, which is to identify patients who have high risk disease, but are sort of at the lower end of the high risk spectrum, if that makes sense, in whom we don't want to do further dose escalation. And so in COG, these patients with localized disease that's not MECAN amplified, that is unfavorable, that in North America are considered high risk, in Europe have been considered intermediate risk. Those we consider high risk, but we don't further escalate their treatment on study. And so I think actually the first group that we'll create is high risk, but as it were, not high risk. We haven't really worked out what they're going to be called yet. And then there is a lot of work to identify the ultra high risk patients. The real challenge is going to be what we do with that information, because none of us have got a secret magic strategy that we're keeping in our back pocket for a rainy day. We are already using everything we think that is helpful. And so I think it's going to be really challenging. And I think actually it may be that instead of drawing out a risk group based on kind of being ultra high risk, we'll draw out other groups based on molecular pathways that are abnormal in those tumors, like the ALK, so that we've then got something specific that we could offer. And so maybe patients with things like ATRX abnormalities, if we can get to the point of finding a decent drug or a way of targeting that, might be a group that we can separate out.
Okay. Excellent. The next question has to do with side effects. So Jennifer, could you talk about the enlarged pupils after treatment, and in some cases starts early on in immunotherapy? Could you speak to that particular side effect? And is it done?
Sure. So we do see that in some patients. And when we see it, we want to first, of course, have them evaluated by an ophthalmologist and make sure that it is related to the treatment and not another underlying problem. But it is pretty commonplace. We do sometimes kids need things like glasses to support them because they have some blurry vision along with it. It is something that otherwise doesn't generally bother them. So a lot of kids using glasses is really all they need to do. And we just keep an eye on it. And also they continue to be followed by the ophthalmologist to make sure, again, that it's not another underlying process.
And does that resolve over time after immunotherapy?
Yes.
Is there a typical timeline where you see that resolve?
The amount of time it takes I think I've seen kids as long as a few months after treatment that it takes to. Some seem to have it go away quicker, but I definitely can remember kids for at least 3-4 months having it.
Okay. Very good. Now, there's a couple of questions regarding the tandem transplant, and one of them is, a little commentary on why SciPen hasn't adopted the tandem transplant. Of course, you spoke to these plans, Daniel, about what's happening in the current HR2. But then another question related has to do with, the question: are clinicians concerned about the toxicity and potential late effects of the tandem?
Yeah. So I have to be careful what I say now. I've just seen Dr. Park joining, who is the global expert on tandem transplant. So, I think the important thing to say is a lot of this we'll cover in more detail in the specific session on this. I think, the challenge for SciPen in just saying, okay, we're going to immediately adopt tandem is that, of course, the European standard for high-dose chemotherapy is busulfan melphalan, because that was shown to be better than SEM, the other chemotherapy, following SciPen induction chemotherapy. And so I don't think it would have made a lot of sense for Europe to throw that result out and to swap over to the COG tandem approach. And that's why I think SciPen have taken a very sensible kind of pragmatic approach of saying, we think in Europe, Bumel is the standard after our SciPen induction. And we're now going to see, can we further enhance the efficacy of that by using a tandem?
Very good. Thank you. Any thoughts on that, Dr. Park?
No, I think I grasped the question, but I do. It is a little stepwise because Bumel is better than SEM. Our tandem has SEM. It's not a head-to-head comparison. But what I do think has been really exciting is that really over the last decade, we are so much more aligned together, sharing our results very early with each other so that we can really inform, and that we are making advances along the way to really inform how we move treatment forward. And I think that the story for patients who have tumors that harbor ALK mutations is really a great story of the work that we did to really align, even though the backbones are slightly different across all the world, we're aligning all the studies that we're doing across those trials so that we can share that information together and work together with that group. And that's a small subset of children with neuroblastoma, but I think it's an example of what we can do if we continue to work together that way.
That's great.
And Donna, I realized I didn't answer the second part of the question, which was, are we concerned about doing tandem and the toxicity of it? And I think the honest answer is we are. And I think, as clinicians, we don't give these treatments lightly. And, in many ways, it would be ideal if we had evidence that that there was no benefit from further dose intensification, but that was not what the studies showed us. And so at the moment, it's really difficult to think about reducing therapy at a time when we still need to improve outcomes.
Yes, for sure. We would love a day where we felt like we had good enough response of patients to our upfront treatment that we could really readdress. Could we, in some patients, not use such aggressive therapy? Absolutely. And I hope that's in my lifetime.
I hope so too. Now, it's nice timing for you to come back, Dr. Park, because there's several really good questions about imaging. One is it possible to have a mix of MIBG avid and non-avid disease?
Yes, and I'm sorry I didn't say that during my presentation. Yes, and that would be another reason why you might want to consider utilizing PET scans or alternating between MIBG and PET. Neuroblastoma is such a unique disease, and it can be so different in different patients. So what we say is the global way to do things works for the majority of patients, but there are always patients such as that, especially in the recurrent setting where sometimes patients can have MIBG avid and non-avid disease. I think the point is that functional imaging is important and utilizing one of those two techniques is very important.
Oh, good. And related to that, how common is it for MIBG avid disease to turn non-avid? In other words, like say in the relapse setting?
It's not, it happens. It's at a relatively low rate, even after patients who have received therapeutic I-131 MIBG, but it can happen. So I think that is just something that is individually identified in patients. Okay. It's not so common that I think every patient should always get an MIBG and a PET at the time of recurrence. But I do think that if there's ever a consideration that there might be something seen on the CT scan that isn't being seen on the MIBG, then those patients should get a PET scan.
Okay. And well, related to that, one parent wanted to ask, what's the benefit of MIBG scans over PET? In other words, why not just use PET all the time?
Yeah. So PET takes up any metabolic activity. So it is very sensitive, but it may not be very specific, so that you can have situations where the PET is abnormal, but it's actually not neuroblastoma. So for instance, if your bone marrow is recovering after transplant and you did a PET scan, a lot of your bones would light up because your bone marrow is metabolically active, reestablishing your hematopoietic cells. If there's infection, that can light up with PET. So you balance the two. MIBG is most specific for neuroblastoma, but as we said, there can be cases where it's not as sensitive. So trying to understand ways that we can better utilize MIBG for the majority of patients who have uptake of MIBG, and then utilize something that's a little less specific, like PET, is always a good backup.
Okay, fantastic. There is another question about MIBG non-avid disease. There was some evidence some years ago that they might have a slightly better prognosis. Mm-hmm. And if so, do you know the mechanism or rationale or biology?
We do. We've looked at that retrospectively in the children's oncology group cohorts, and we're actually studying that prospectively to just say, is it true that patients, the 10% of patients who don't have MIBG avid disease, do better? So I think that'll be the first trial that actually prospectively looks at that group. There are some different hypotheses, but nothing really borne out mechanistically in my mind. Maybe Ramya or Daniel, you think otherwise, but I don't think we really understand it at this point in time.
Okay, well, thank you. Well, this question might be a good one for you, Dr. Ramya. There's a general question on how patients are selected for phase 1 studies. And in this particular parent was interested in the emerging imaging options, if there are studies for the new imaging options that Dr. Park talked about. But I guess being selected for a phase 1 in general, could you speak to that?
So in general, I think if you're trying to say that the common or the known established modalities of treatment are not working and the child has refractory resistant disease, then obviously then we want to look at what are the other options available. And in that context is where we go into phase 1 studies and the availability of phase 1 studies. So at the moment in the UK, we have what is called the ECMC meeting that happens on a regular basis, on a weekly basis. So this is where the patients get discussed. In addition, when the tumor is refractory or the tumor is a relapsed tumor, we try to do once again a molecular analysis. And there is an open study now called the SMPEDS, which is a stratified medicine for pediatrics study. So based on what characterization and biomarkers come from that, and then we have a discussion within the SMPEDS MDT, as well as in the ECMC meeting to see what phase 1 studies are available in the context of refractory relapsed disease. So that's sort of the general principles of how patients get selected, you can say, for phase 1 studies.
Excellent. Thank you.
And Donna, maybe I just add, I think it's a really complicated topic because it's actually very hard to keep up to date with what trials are available, where are they open, what are the eligibility criteria, who are they suitable for. And the bottom line, I think, is that parents don't need to feel that they've got to do that work themselves. That should be something that their oncologist can do. And if their oncologist says, I don't know anything about this, then I would encourage them to ask for a referral to somebody who does, because I don't think any of us would be upset about being asked for a second opinion or for our patients wanting to talk to somebody else for a second opinion. So I would encourage parents, if they want to know more about clinical trials because they're in this sort of situation, to ask for more specific information.
Very good.
I would love to second that, Daniel. I think, it's very hard to be contacted directly by a parent because as much as parents know deep down everything their child has gone through, you may not know some of the specifics that would trigger our mind to go one way or the other. And so what I generally try to do when families contact me directly is please ask your oncologist to reach out to me, because even if I don't feel like I'm the best person to see that, I could tell your oncologist, maybe you should reach out to this center, or this center is closest to you. And so I think we're all willing to do that. I think it's just super helpful for us to speak directly to your doctors, just because we can then really hone in on the information we need to quickly help to sort what's the best direction.
Actually, that reminded me, Julie, because in the UK, apart from this ECMC and the SMPs, we also have our National Neuroblastoma Advisory Panel that I actually chair, and that is one of the roles of that panel as well. So we get oncologists, the local oncologists, to come and present their patient with all the details. So then you get a combined decision from the experts as to what is the best way to go forward and where that's available.
Fantastic. That's good to know. I have a question for Jennifer on the toxicity of treatment. And the question specifically refers to the really young patients. And the parent wants to know, is there nurse-led research in this particular area? Focusing on the youngest set that go through these very intense treatments.
So I'm not aware of specific studies going on in nursing about infants particularly, but side effects in general, there are definitely ongoing studies that accompany other clinical trials that are looking at side effects in patients overall. But you're exactly right. It is something that needs, the toxicities can be, really difficult to manage and to live through as a patient and a family. But no, I'm not exactly certain of any specifically with infants.
And do you see a difference in late effects between the infants who are, or toddlers who are treated versus slightly older children?
I think it depends on the type of treatment that they're getting. So the younger kids are often getting treatments that aren't as intense, which is a good thing. So we see less side effects and less late effects. The kids that get the more intense treatment, of course, there can be late effects that we have to manage. But the good thing is we know about those and we know how to manage them. So if your team is, helping guide you through that and actually transitioning you to a team that specifically focuses on those long-term effects, late effects, then we should be able to help manage all those side effects.
Thank you. Now there's a couple more questions on imaging. One has to do with how much radiation from specific modalities for imaging. For example, is an MIBG SPECT CT more radiation than a regular CT? Or what about PET? What's the difference in radiation exposure?
Yeah, I don't have those all right in front of me, but they all have radiation exposure. So the SPECT CT aspect, if you just take that CT, it has less radiation exposure than a normal CT scan. But then you add on top of it the fact that you're giving a radiolabeled nuclide with the MIBG, then they end up being somewhat similar. I think if we can get to a point where imaging that can be combined with CT or MRI, functional imaging, we could get to a point where we could get rid of the old-fashioned anatomic imaging and maybe rely more on that. Bottom line is all imaging at this point in time have risks. MRI obviously doesn't have a radiation exposure, but most children have to be sedated to be able to lie still. And we now know in very young children that repetitive sedation isn't the best thing in the world for a developing brain. So I think there's risks in all of it. So I do think this gets to this whole balance of how much do you image and when do you stop imaging? And that's a controversial, I don't know the right answer to that. That's controversial, and we could spend an hour talking about it. Yeah. But I sometimes say to families, which this will sound very cruel, and I don't mean it that way, but imaging does not prevent recurrence. And so if you do an image every 6 months versus every 3 months, and you find it at 6 months instead of 3 months, it's not because you missed it. It was happening. And whether you imaged then and didn't see it, or didn't image and didn't see it, it's a balance. And we don't know, what's the lowest level of disease that's most treatable if it were to recur. We don't know, is it that some patients recur really slowly, and so when you pick up small amounts, they have a different type of disease and maybe they'll respond to treatment, whereas other children you could be scanning every month and you'd still have them show up with widespread metastatic disease. So it's very hard, and I think that's why many of us try to balance how often we scan, especially following completion of treatment, because there are risks to the scan right now.
You're right. Extremely important discussion. We might have to do another session someday just on that topic, because I think there's a lot of interest there. Yeah. Now, here's a question. Ramya, you may take this one, but I'm sure Julie and Daniel, you'd have something to weigh in. One question is, if you have a focal relapse or localized disease, is there any danger when you biopsy that to spread the disease?
Not necessarily, because that's what we discuss with our surgeons, intervention radiology team, to see what is the safest way to do it. And ultimately, we're going to be starting treatment. And the aim of treatment is to get rid of disease, including systemic disease. So that way you're double proofed, if you want to say. A, make the right decision, what is the right area to go to and the right person to do it as safely as possible. And B, the child is going to follow it up with treatment. So you are going to take care of any cells, minimal, if at all there has been any spread, because it's systemic treatment is what we're going to be giving.
Okay, very good. That makes sense.
Totally.
Now, we have another question on what about survival rates. A lot of times all of the high risk are combined onto a single curve. And the question is, do you know if there's a difference in the survival rate, say between 2 years old and 4-year-olds, or do the same statistics apply to all age groups?
Yeah. So this is kind of really critical to understand. And I think these survival curves that we often show in our talks are actually much more complicated than we let on. Especially because actually on the right-hand side of the curve, there are very few patients and very little data really. So really what they're about is the data on the left-hand side. I think what's really important to say is that the outcome of the group of patients depends on where you're starting to look. And so the outcome for a group of patients at diagnosis is different from the outcome of a group of patients at the start of high-dose chemotherapy. And it's different from the outcome of a group of patients at the start of immunotherapy. And it's different from the outcome of a group of patients who start from the point when they finish treatment. Because at each of those points, as you grow through therapy, the patients who sadly disease has not responded well or who's progressed come out of that data set. And so as you go through, you're left with the patients whose disease is doing well, doing what you wanted to do. So it's really important for anyone who's looking at papers to not just look at the headline number of 60% 2-year survival, 80% 2-year survival, 40%, but to say, where is that starting from? And that's really important also for families when they're talking to their clinicians, if you're the sort of family who want to know statistics, is that the statistics we might give at diagnosis are not going to be the same as you go through treatment. And if you don't ask again, you may not hear that additional information. I think in terms of this specific question, I think there's probably not much difference between the outcome from a 2-year-old and a 4-year-old. But on the other hand, we do know that age is a relevant factor within the high-risk population, and that patients who are older, so older than 5 years, for example, do have a less good outcome than patients who are younger. And clearly the tumor doesn't know when the patient's birthday is, so there must be something to do with the biology of the tumor, and probably that is a gradation between the different age groups. And so potentially at some level, a 4-year-old might have a less good outcome than a 2-year-old, but it's not enough of a difference to demonstrate statistically.
Great. Thank you. Now, here's a question for Dr. Ramya. They want to know your opinion about the tandem transplant from a UK perspective. So, in other words, if a child's already undergone a single high-dose chemotherapy, would you recommend seeking another transplant if it was possible?
So again, that is something we constantly discuss within our National Neuroblastoma Advisory Panel. And it is dependent on a number of factors. A, how well the previous transplant was tolerated, what is the current morbidity, what is the current toxicity the child is experiencing, where are they in terms of response, has it been a very good response at this time point? And taking all those into consideration, and obviously the availability of the donor, where is it going to happen? So in other words, there are a lot of factors, pre-morbidity, morbidity, and what's going to happen next that has to be taken into criteria to determine, yes, is this child fit for a tandem transplant? And I do know, yes, there are some situations where it has happened, and there are some situations where we have said, well, actually, this child is not fit for a tandem transplant because of where the current situation is with regards to the disease, with regards to the toxicity, and what's going to happen next.
So then we have another question on some of the consequences of cancer treatment and on male fertility. What's the latest that we know about that consequence?
So we do know, yes, male fertility is going to be affected. And so, in fact, just 2 days ago in our national meeting, we had the late effects symposium. And the recommendations or other thoughts were, what is an ideal time point in terms of males and what type of fertility preservation we can do in terms of males? Because obviously, majority of these are young children. So we're not going to have any mature sperms. So is it worthwhile doing some testicular cryopreservation? But equally, the question is timing. So what is the ideal timing? So the proposition was we cannot do it at the time of diagnosis when the child is so unwell. And sometimes there are some risks as well in terms of the edema that's going to come up in that area and delaying the start of treatment because of the consequences of the surgery procedure itself. So if there is an opportunity at that time point, from the time of diagnosis to start of treatment, whether we should utilize that opportunity just before the start of chemotherapy is one, but I don't think there's a complete consensus as to what is an ideal time. Because we know that in the context of males, some of the drugs that we use will be gonadotoxic. So whether we do it after induction, that could be another option. However, there would be some expectation of some gonadotoxicity at that point, but that's a compromise if they can't do it in the beginning. So I didn't know what the North American experience is or what thoughts are.
I think it's pretty similar in that there is definite concern for fertility, both in males and females, or in females. Jennifer can speak to this, but early onset for ovarian failure following treatment, et cetera. And the right way to approach this is complicated because, and the risk, I should say, is more likely in the high-risk patients. As Jennifer said, our whole goal in the patients who do not have high-risk disease is to give less and less therapy. And so hopefully in those children, that's not a given that there'll be infertility problems. But in patients with high-risk disease, it is. And what you might do as far as ovarian or testicular preservation and when you do it is difficult. We've had some discussion about trying to do it at diagnosis at the time that maybe a line was put in, but when you think about how sick some of those children are, it is difficult. So I think the earlier during treatment, the better, obviously, so that you can preserve that. But I think this is all still in the research realm, unfortunately.
Yeah, I mean, that's what I was going to add, because unless I'm not up to date, at the moment, the ability to actually produce mature sperm from stored pre-pubertal testicular tissue doesn't actually exist yet. So this is kind of storing tissue for future.
Yeah, there's an ongoing study that just opened kind of nationally that will actually look at, the ability to really do that in a feasible way in more children early on in treatment. So hopefully we'll have that information.
Well, we only have a few minutes left, and Jennifer, you only have a few moments left, but one last question for you and then one following. Jennifer, can you speak to parents who are seeking alternative or complementary medicines to try to treat side effects? Can you, help us out with what you would advise families who are looking in that realm?
I think the first thing I'd like to say about that is you need to be honest with your treatment team about what you want to do for your child, with your child, different things you want them to have, other medicines, other therapies. And then it's our goal as a team to help figure out how we can make that happen. So certain programs have integrative health programs. We have one at CHOP that we use, and it's great. And I'm learning more and more about those different types of things that I was never really comfortable with. But it's not that we don't want to encourage people. It's a little bit of the fear of the unknown about what will those treatments, how will they impact the other treatments your child is getting. So I think I would say we definitely don't want to tell parents not to do this. We just need to know what is their intention, what is their goal, and then to try to work together to figure out how we can safely make that happen.
Thank you for that. Well, we're out of time now, but I want to thank all of the presenters for this excellent time. You've covered a vast amount of information, and I'm sorry we couldn't get to all the questions, but hopefully in future sessions that are more specific to some of these topics, we'll be able to cover those as well. But you've all done such a brilliant job, covering such difficult topics, and really appreciate your time. It's one thing to have the expertise, on a presentation like this, but then for you to share your valuable time with us is we're extremely grateful. And Jennifer, I know you are in a special family time that you took away to do this, so thank you all.
No problem.
Now we hope you'll be back about 20 minutes after the hour for our next session. Come right back to this this spot. Thank you so much.